Welcome to the introductory presentation for patients referred to the Provincial Bariatric Surgery Program in Newfoundland and Labrador. We would like to welcome you to this presentation. Before beginning, I would like to acknowledge the work that Raylene Murphy has completed over the past several years in adding extensive knowledge and resources within the bariatric surgery program. Some of her slides have been modified in the making of this presentation. The purpose of this presentation is to provide information about the bariatric surgery program. You will quickly come to realize after listening to this presentation that bariatric surgery is a dramatic and permanent lifestyle change that puts overall improvement in health as the main goal of surgery. After viewing this presentation, patients should have the knowledge to make an informed decision about their choice to participate in the program, have surgery, and commit to the lifelong changes to ensure their success. With this in mind, I encourage you to make notes as we go along and formulate any questions you might have throughout so that you can ask at a later date. The objectives for this presentation are to introduce you to the members of the bariatric team, to provide you with an overview of obesity as a chronic disease, to discuss the criteria that patients must meet to be considered for bariatric surgery, to review what you can expect in terms of assessment with the bariatric team prior to surgery, to provide a description of the procedure, both pre- and post-operative care, and the benefits and some complications of bariatric surgery. We will also discuss the follow-up process after surgery and any dietary or nutritional considerations. Finally, a summary of the content will be offered, as well as a few helpful resources that we have to share with you. The Provincial Bariatric Surgery Program was established in 2011. It consists of 3 surgeons, 1 full-time nurse practitioner, 1 full-time registered dietitian, and a part-time secretary. It is a surgical program whose main focus is to identify appropriate candidates based on referral criteria, where selection of candidates who are likely to have the most benefit take the overall priority. It is a perioperative education process and includes extensive follow-up that will rely heavily on supports already present in the community. These include your primary care provider or your family doctor. What is obesity? Obesity is a chronic and often progressive disease with risk of relapse mediated by neurohormonal factors. This definition sounds pretty complicated. Well, it is. Obesity is now considered a chronic disease in the medical field. This is due to the overall health impacts it can have on our bodies. The progressive nature of the disease means that if left untreated, it will become worse, and even with treatment, there is still potential for worsening of the disease. The relapsing nature of the disease refers to the possibility of weight gain after loss occurring. Weight loss may not be permanent despite the treatment you choose. We are all familiar with diets where you lose 20 pounds and gain 30 back in the near future. This occurs because the body will do absolutely anything it can to survive, and it actually views weight loss as a threat to its survival. In today's society, we do not face the same challenges as previous populations in regards to food security, nor do we need to work extremely hard to find our food sources. Ultimately, the body is built to protect itself from periods of starvation during times when food is not available, even though, as I said, this is not the case today. When we speak about the neuroendocrine factors, this refers to certain hormones in the body that create the feeling of fullness or satiety. These hormones may not work in the same way in a person with obesity. I'm sure you've all heard of the term BMI. BMI stands for Body Mass Index. It is a tool used along with a health history to determine your risk of developing certain health problems. It is expressed by weight in kilograms divided by height in meters. It is used only in individuals 18 to 60 years of age and therefore is not used in children, the elderly, or pregnant or lactating women. It is less useful in bodybuilders, and this is due to their body composition. The major concern or problem with BMI is that it does not take into account fat distribution, percentage of overall fatty or adipose tissue, and it also does not differentiate between fat mass and muscle mass. It also does not take into account body shape. As we all know, we are all different shapes and sizes, and your overall body shape can be a key predictor of health risk. Generally, those who carry weight around their midsection are termed apple-shaped, and those who carry more weight peripherally are termed pear-shaped. As a general rule, apple-shaped individuals tend to be at a higher risk for certain disease. If you look at the diagram here, you'll see that a normal weight is referred to as a BMI calculated between 18.5 and 24.9. As we go down through the chart, overweight is 25 to 29.9. 30 to 34.9 is obese class 1, 35 to 39.9 obese class 2 or severely obese, and a BMI of greater than 40 is obese class 3 or morbidly obese. So what are the factors that affect obesity? There's such a complex interplay of factors which affect the development and its progression. These include societal influences, such as the media, education, income, and gender, food production, so where does our food come from and how is it produced, food consumption, what, where, why, and how we consume our food, individual activity, which is our level of activity, environment, our upbringing, where we lived, influences from friends, family, etc., our biology, which is our genetic makeup, and individual psychology, which is how we each think and feel about ourselves. A simple view of calories in versus calories out is way too simple to define obesity. Patients feel stigmatized as many times there is a common assumption by society and even healthcare providers that patients who are obese simply eat too much and don't exercise enough. Without going into a great deal of detail for each category listed in this slide, the main point to think about here is that obesity is a complicated disease which is not amenable to simple or short-term solutions. In saying all this, think about what factors are affecting you in your own life and what you can change that would make a difference. How can you make changes that are sustainable in the long run that you could actually maintain for the rest of your life? If you try and make these changes, but the people around you do not, how will you feel? And how will you adjust to this transition? Treatment for obesity. When it comes to the treatment of obesity, there is definitely no quick fix. If you think this, you will be setting yourself up for failure and disappointment. Rather, let's just focus on meaningful lifestyle changes that are sustainable for improving health. While this does include eating well and exercising, it is important to concentrate on improvements and how you feel rather than how you look. There are a limited number of medications that are effective, accessible, and affordable in Canada. One type of medication available on the market is a glucagon-like peptide 1 analog, or GLP-1 analog, and you may have heard of this called Saxenda. This medication is expensive if you do not have insurance coverage. As well, it is administered as a daily injection, which many people are simply not interested in doing. The weight loss benefits are not as dramatic in comparison with other treatment options, such as bariatric surgery. Another option is an oral medication called orlistat. However, there are many side effects associated with it. The most complained about side effect is that the drug causes you to excrete fat in your stool and you may have symptoms of cramping and diarrhea. Bariatric surgery is an option for weight loss if lifestyle changes are unsuccessful. Bariatric surgery refers to the actual surgical procedure. It is a tool for weight loss, but is not a cure. The amount of Canadians who are eligible for bariatric surgery greatly exceeds the number that could ever be accommodated by the available resources. This includes our own province of Newfoundland and Labrador as well. However, surgery can lead to meaningful weight loss and a drastic improvement in overall health. So, just to summarize that up, bariatric surgery is not and cannot be the only treatment for obesity. It is certainly not for every patient, and every patient should be viewed in a unique light. It is not a quick fix, and it is not an alternative to healthy eating and overall lifestyle change. It does not lead to normal body weight in most cases, and we will talk about this a little later. Obesity treatment requires long-term management and permanent lifestyle changes. So who's a candidate for bariatric surgery? The minimum requirement is a BMI that falls within a range of 35 to 60. If your BMI is below 40, you must be diagnosed with a comorbidity such as high blood pressure, diabetes, sleep apnea, etc. The program cannot take on patients that fall outside the acceptable BMI criteria. Therefore, if your BMI BMI is too high, or if you have other contraindications to surgery that arise, you will need to work on dealing with those with your primary care provider before we can move you forward. Other factors that we look at for referral criteria are an age of 18 to 60 and an overall stage of readiness, which means that you are already adhering to dietary and lifestyle changes. Another criteria is that you've already had multiple attempts at weight loss in the past through other efforts, and that you're medically appropriate. For example, your diabetes is controlled, your sleep apnea is treated with a sleep apnea machine, and your blood pressure is managed. As well, you must be psychologically sound and have reasonable expectations for weight loss. You must also demonstrate compliance with food journaling, label reading, meeting protein, hydration, and caloric targets, and be able to eliminate all pop, all caffeine, and all alcohol. So to summarize, you are not a candidate for bariatric surgery if you have had a drug or alcohol dependence within the last 2 years, untreated or inadequately treated psychiatric illness, pregnant or planning pregnancy within 18 months of surgery, a recent major illness such as cancer or heart attack, or if we have overall concerns about your compliance with nutrition and behavioral change. Evaluation. Your preoperative evaluation includes all of these categories seen here. These include a medical assessment, a psychological and behavioral assessment, laboratory and diagnostic testing, physical assessment, and a nutritional and psychosocial assessment. We take all of these categories into consideration when we consider you as a candidate for surgery. After your initial meeting with the nurse practitioner and registered dietitian, the decision will be made on whether or not you will be appropriate for the next step. The next step would be meeting with the surgeons to sign your consent for surgery. Generally speaking, your OR should take place within 6 months of signing consent. However, this can vary depending on the program's capacity and the number of referrals at any given time. You will be given as much notice as possible to prepare for your surgery. So let's go over the main procedure that we perform here, and that is a laparoscopic sleeve gastrectomy, or LSG for short. As mentioned, this is the most commonly performed procedure at the Health Science Center. If this procedure is contraindicated, they may do a gastric bypass procedure instead. However, this is a decision that will be made between yourself and the surgeon. Gastric banding, or a lap band, is not a procedure offered in this province. Laparoscopic sleeve gastrectomy is a procedure where the stomach's majority is removed, approximately 75 to 80%. It is therefore viewed as a restrictive procedure, meaning the amount that a person is able to take in is greatly diminished. There is also a decrease in the hormone that controls hunger, called ghrelin, and most patients after surgery do not feel hungry at all and actually need to remember to eat. This is why it's so important to have a plan in place to meet your nutritional needs. Technically speaking, lap sleeve gastrectomy is an easier surgery than some other procedures. It decreases stomach capacity to about 1 cup, and you are left with a banana-shaped stomach or a pouch. At the end of the presentation, there's a link for a YouTube video if you are interested in watching a short video on the actual procedure. Here is a picture of the sleeve gastrectomy procedure. The diagram on the left shows colored dots on the patient's torso, which show where your incisions will be. These will serve as passageways for the surgical tools. The laparoscope is the instrument seen there, which acts as the eyes of the surgeon. The stomach is then resected, and staples or clips are placed. A leak test is then performed to ensure that no fluid leaks out through the staple line or any bleeding occurs. If you do have contraindications to the gastric sleeve procedure, the surgeon might suggest you have a gastric bypass, also known as Roux-en-Y. There is a higher incidence of malabsorption of nutrients, which can lead to nutritional deficiencies due to the fact that the small intestine, or jejunum, is rerouted to the gastric pouch or sleeve. This part of the small intestine is where most absorption occurs. There is also a decrease in the amount of the hormone ghrelin that occurs with this procedure, as with the gastric sleeve, causing a decrease in hunger. Gastric bypass is technically more challenging from a surgical perspective and takes a little longer in the OR to perform. There's also a risk for more food intolerance postoperatively, and close follow-up is a necessity. Benefits of bariatric surgery. Some things that might occur after surgery are an improvement or resolution of your diabetes, improvement in control or complete resolution of hypertension or lowering of your blood pressure, lowering in cholesterol, a decrease in incidence of sleep apnea, and an increase in quality of life or life expectancy. Everyone's experiences after surgery are individual, and not all patients may achieve the same outcomes. Therefore, it is important to remember not to compare yourself with someone who had the same surgery, as this may not always be helpful or realistic. We encourage our patients to be mindful of this as they go through this journey. Let's talk about some early surgical risks. These risks can be further explained to you by the surgeon if you have any concerns at your preoperative visit. Briefly, these risks include leak along the surgical staple line, bleeding, infection, internal organ injury, conversion to open procedure, which basically means that the surgeons would need to make a larger incision as they cannot visualize through the small incisions, blood clot, heart attack, stroke, and death. These last complications, heart attack, stroke, and death, are a risk that occurs less than 0.5% of the time. While these are very minimal in risk, we always need to discuss these with the patients. If you have any concerns, this is important to bring up in your meeting with the nurse practitioner or surgeon. Some late surgical risks are listed here. These include a stricture or a narrowing of the stomach outlet, gallstones, which can develop due to rapid weight loss, a fistula, which is a tunneling or opening between two organs, an incisional hernia, which can develop along where the cuts were made, nutritional deficiencies, hence why we follow up so closely with you after surgery and with blood work, as well as weight regain and recurrence of comorbidities such as high blood pressure and diabetes. This is why it is so important to talk about permanent lifestyle change and changes that you can make that are sustainable so that you can be successful. Next, let's talk about the pre- and post-operative process. The liquid diet prior to surgery seems like a very difficult task for most patients, but it is a very important part of the preparation because it helps to shrink the size of your liver. When the surgeons go into the abdomen with the instruments laparoscopically, the liver is retracted or pulled to the side to get a better visual of the stomach itself. If the liver is too large, it can be very difficult. The liquid diet preoperatively allows for the liver to shrink to ensure adequate visualization. You will be seen at the pre-admission clinic at the Health Science Center the week before your surgery, and all the surgeries are completed on Monday. The sleeve gastrectomy takes approximately 1 hour in the OR. However, the gastric bypass takes a little longer, around 2 to 3 hours. Postoperatively, it is important to prevent blood clots, so you will be given support stockings or compression stockings to wear. You will also be given a blood thinner after surgery in the hospital. The nurses on the unit will encourage you to get up and mobilize and walk as soon as possible to help with blood flow as well. This may mean taking your IV pole to the bathroom or around the unit to walk. The nurses will also closely monitor your vital signs and your blood work. In the hospital, you will be given nothing to eat or drink after the surgery, and you'll be placed on IV fluids. You will be instructed to increase your fluid intake very slowly, and the registered nurses will help you with this. The dietitian and nurse practitioner will see you in hospital the morning or afternoon after your surgery, and usually you are sent home that day. If you live more than 1 hour drive away from the Health Science Center, you should make an arrangement to stay in St. John's until the end of the week. Some common issues after surgery that patients experience are reflux and heartburn. Some patients who have pre-existing reflux actually find that theirs may resolve or get better after surgery, and some patients may find it gets worse. However, there are medications to help with this. Some other common issues are nausea and vomiting, which is usually only in the immediate postoperative period. Dehydration and constipation are things that we caution patients about after discharge from the hospital. You will need to work hard to meet your hydration requirements to not only avoid constipation, but also the development of gallstones or kidney stones. Some other issues are fatigue, hair loss, feeling cold, emotional struggles due to a loss of eating, which equates to a loss of a coping strategy for some people, We will be monitoring your blood work for signs of nutritional deficiencies that can have an impact on overall health. Patients do get concerned about hair loss. The reason that hair loss occurs is because your body considers the rapid weight loss to be a stressful event. Hair loss cannot be predicted for each person. Fortunately, if it does occur, it is temporary. Ensuring that you are meeting your protein and nutrition targets can help. The emotional side of this process can be very difficult for patients, despite adequate support. Reflect on your current situation and determine if you use food to cope with your various emotions. What do you anticipate will happen if you cannot use food as a coping mechanism after surgery? How can you cope with and be successful mentally and emotionally? Excess skin is also a common concern among patients. This can be addressed postoperatively and requires referral to the plastic surgery team. The area below the belly is usually covered by MCP, and any other surgeries besides the lower abdomen would require out-of-pocket payment by the patient. Next, we're going to talk about weight loss expectations. Once again, it is very important to avoid comparing yourself to other people who have had the same procedure, as everyone's experience is individual and unique. The focus should concentrate more on how you feel rather than how much weight you can lose. It is important to note that after surgery, most patients do not ever reach BMI range that is considered normal. Rather, patients can expect to lose about 25 to 30% of their pre-surgical weight by the 12 to 18 month mark. Let's look at this example. If a patient weighed 300 pounds at their start preoperatively, you can multiply that by 25% or 0.25, or you can multiply it by 30% or 0.30. In this case, 25% will be equal to 75 pounds and 30% will be equal to 90 pounds. Therefore, it is expected a 300-pound person at 12 to 18 months after surgery would lose approximately 75 to 90 pounds. It is important to keep in mind that this is only an estimate. It will be impossible for us to predict exactly how much weight each person will lose. Some patients may lose more or less depending on a variety of factors that come into play, such as medical conditions, individual biology and genetics, the amount of physical activity they perform, and others. At the 12 to 18 month mark, weight loss does slow and reaches the plateau. Some patients may even see a slight regain of 8 to 10% of their weight lost. This is normal, and patients should not be discouraged. When setting weight loss goals, it is important to be realistic and set achievable goals so that you do not set yourself up for disappointment. As well, it is important to not compare yourself to other people you know who've had this procedure. Everyone's experiences are unique based on their own individual factors. As we talk about realistic goals for weight loss, I think it's just as important to talk about the normal path of weight for not just bariatric surgery patients, but all of us. If you look at the graph image on this slide, you will see years shown along the bottom axis, which as we move along that line indicates our age increasing. On the left-hand vertical axis, we see weight, and as we move up that line, our weight is increasing. From the line within the chart, we see many ups and downs as we get older. This change in our weight could be for various reasons: diet, stress, medical reasons, etc. Essentially, however, we are all on the upward path in terms of weight gain. As we get older, our bodies tend to gain weight. For some patients, that could look like a 2-pound gain within a 10-year period, while for others, this could be a 200-pound gain in a 10-year period. Eventually, a patient may decide that the time has come to do something about their weight. As we know from earlier in this presentation, our treatments for obesity include lifestyle, which is healthy eating and physical activity, medications, and then lastly, surgery. As we can see on the last tab there for surgery, we see the greatest drop in weight loss indicated by that line moving downwards. With lifestyle and medications, we also see some modest degree of loss. However, as we know, surgery leads to about a 25 to 30% drop in weight. However, after all of these treatments, while our weight may drop initially, it may then again increase. Some regain is normal, as we've already talked about. However, it is important to recognize that surgery may not be the only treatment you need for obesity, just as with any disease. Next, we're going to discuss follow-up after surgery. You will see the nurse practitioner and registered dietitian at 1 month, 3 months, 6 months, and 12 months after surgery, and you will see the surgeon at 6 to 8 weeks after your surgery. You can also expect to follow up with your primary care provider as needed. For those patients who live outside the city of St. John's, follow-up appointments will be arranged through telehealth at the site closest to your residence. It is important to let us know about availability early so that we can arrange your appointments appropriately. Many patients will require adjusting or decreased doses of their medications for conditions such as high blood pressure and diabetes that we expect will improve with rapid weight loss. Some people may even see a discontinuation of medications relatively quickly in the postoperative period. This is why it is so important to have close follow-up with your family doctor or primary care provider after surgery. All patients who are diabetic should know how to treat a blood sugar low and know the signs and symptoms. It is also important to monitor for drops in your blood pressure, which can cause symptoms such as dizziness, weakness, and fainting. During the preoperative liquid diet, patients who are diabetic may also need their insulin or diabetic pills adjusted, as their calorie intake is probably much less than before. If you are unsure of what to do, please consult with your primary care provider or the nurse practitioner in the bariatric program. Expected return to work. Most patients return to work by 4 weeks post-op. You will need to avoid any heavy lifting in the first 4 weeks to a minimum of 5 to 10 pounds. And if your work involves heavy labor, you should wait 4 to 6 weeks to return. There is no restriction on driving, but be cautious of how you feel. If you are experiencing a lot of nausea or fatigue, it is best to use your own judgment. In the early postoperative period, light walking on a flat surface and for short distances is appropriate. The early postoperative period is not the time to take on any strenuous physical activity or anything that is taxing on the body. Later on, as your physical activity increases, it is important to recognize that your body's caloric needs may increase as well. Swimming is another great activity, but only after your staples have been removed and your incisions have completely healed. Be mindful of the type of exercise you choose to perform and make it enjoyable and safe for your body. It should be challenging, but not damaging to your body. It will help to maintain weight loss and has overall benefits for emotional and mental health. Generally speaking, the first year after bariatric surgery is titled the honeymoon phase because you're experiencing all this weight loss as you start on fluids and progress into a soft diet and then a maintenance diet. You are transitioning to life with your new stomach. There are many changes physically, as well as mentally, emotionally, and metabolically. Basically, you are in a period of constant adaptation. 12 to 24 months post-surgery, you are in the maintenance phase where you are more comfortable with the food restriction and are able to tolerate more food than you could after surgery. Your weight loss will slow or plateau, and many people become frustrated at this point. At this time, some patients may become less compliant with all the behaviors and changes that were new to them after surgery, such as keeping daily food journals, meeting nutrition targets, taking multivitamins, etc. After the 2-year mark, a permanent lifestyle change is present, and some patients do tend to revert back to old habits, and this is where you can see some weight regain. Next, we're going to do a general overview of the diet that you can expect after surgery. This should be initiated right away and includes eating 3 meals a day, every day, without skipping breakfast. Be open to trying new foods that may be different than what you have eaten in the past. Incorporating 2 to 3 planned snacks in between meals is important. Practice mindful eating by sitting down to eat at a table, not eating in front of the computer and the TV or phone, and avoiding any distractions. Planning your meals and snacks ahead of time is crucial to your overall success as we all live such busy day-to-day lives. Know the protein and calorie content of your food by being comfortable with reading labels and knowing how to seek out information. Track how much and what you eat and drink is one of the most important requirements of the program and will lead to long-term success. Start all of these behaviors now through to surgery and forever after. Generally, patients who have practiced these changes do well after surgery as they are not shocked at the massive changes and transition that need to take place. The actual surgical procedure that takes place in the operating room is the smallest piece of the puzzle when we talk about bariatric surgery. Being able to incorporate all of these behaviors and make these changes to your diet and nutrition is massive. Patients do well with these changes when they make the plan to set themselves up for success. After surgery, you need to adjust to eating from a side plate rather than a large dinner plate. The next slide will show an image of a bariatric side plate, and these can be purchased online and are fairly inexpensive. However, they are not required. Your intake changes dramatically after surgery as your stomach now only has the capacity of around 1 cup in size. Therefore, we need to focus on quality of food taken in and not quantity. Again, this is a very basic overview, and if you would like to proceed with the program, you will be given the opportunity to listen to the webinar from our dietitian, which gives a more detailed explanation of all of this. Due to the capacity of your stomach, you don't eat and drink at the same time. So what you want to do is drink your fluids an hour before and a half hour after eating. The main reason for this is so that you do not overfill on fluid and have trouble getting food in, which is of great nutritional value. Eating and drinking together can also cause heartburn and varying degrees of nausea and vomiting. You must ensure you eat slowly and chew your food well and adequately to prevent these symptoms and to ensure proper digestion and absorption of valuable nutrients. This slide shows a bariatric plate that I've already spoken to earlier. As you can see, the protein makes up the biggest portion, followed by your veggies and then your starch, or carb-like foods making up the smallest portion. This amount of food is not something you will be able to eat immediately after surgery, by no means. It is something that you will work up to. Again, you need to focus heavily on the protein, eat that portion of your meal first, and then work clockwise around the plate, consuming the starch portion last, and only if there is room. Vitamins and minerals. Vitamins and minerals are required after surgery and are critical to ensuring that you are meeting your nutritional needs. Due to the size of your new stomach and the amount of food you can take in, it is very difficult to meet these needs. Many times, we start these vitamins when we see you in clinic preoperatively, and I recommend you choose a multivitamin at the minimum now that will work for you and get in the habit of taking it every day. Sometimes, due to a less than optimal diet preoperatively, we may also need to start other vitamins and minerals such as calcium, vitamin D, iron, etc. This will be based on your preoperative blood work and something we can talk about at your clinic or telehealth visit. An adult complete multivitamin mineral supplement is the required choice, and after surgery it is recommended that you take 2 a day and not 1 as the bottle will usually suggest. You must ensure that the vitamin contains minerals as well, and a rule of thumb is to look at the ingredients listed on the back and make sure that there's almost as much minerals listed as vitamins. This will never be exact. Make sure it contains zinc, copper, calcium, and iron, and that it is not a gummy or chewable form. However, after surgery, some patients may take a chewable short term. We always recommend vitamin D and calcium citrate as separate supplements, and these doses are calcium citrate, 1,200 to 1,500 milligrams, divided 3 times daily, and vitamin D, 1,000 international units, or IUs daily. However, many times we increase this dose based on your blood work. The next slide gives a brief overview of the nutritional targets that you must meet after surgery and preoperatively as you follow along with the healthy eating plan. Women must aim for a minimum of 60 grams of protein per day, and men must meet at least 80 grams per day. You can go over this number, but you should never go lower. Calories should equal 1,200 to 1,500 calories per day, and fluid should be at least 2 liters per day. Hydration is very important and critical, as dehydration can be a reason why you may need to be rehospitalized after surgery. Dehydration can also lead to other complications such as gout, gallstone formation, and kidney stone formation. In order to meet the target of 2 liters of fluid per day, you will need to always carry a water bottle with you and be constantly sipping, as you will not be able to gulp or chug water like you could before surgery. You should avoid all carbonated, caffeinated, and alcoholic beverages. Carbonated beverages increase the pressure and gas in the stomach, which can be detrimental on the staple or incision line and may also fill you up. Alcohol is a stomach irritant and can lead to stomach ulcers and other complications. It is also empty calories that provide you with no real nutrition. As well, it may be metabolized differently after surgery in the stomach, and your tolerance may be significantly different. Caffeine is a stomach irritant as well. Choosing decaf coffee or tea is appropriate. You should also avoid highly sweetened beverages that not only provide excess calories, but have no real nutritional value. With the size of the stomach so small, it is precious, and we must ensure we are providing it with the best options we can. Avoid drinking your calories, so to speak. Building a valid and reliable support system is essential to your success after bariatric surgery, and we encourage all of our patients to take control of their health and seek any assistance they may need via the community, family doctor, etc. As most of our referred patients do suffer from chronic disease, there is a chronic disease management program called Improving Health My Way that is a 6-week workshop. For more information, there are numbers listed on the slide. Your primary care provider can also help with referral to any health resources, such as dietitians for diabetes management or lipid or cholesterol management, and counseling for mental health concerns. There's also a community dietitian in the area, such as at your local Sobeys and Dominion, that you may find beneficial. Seek out any other potential resources or support groups in your area, such as walking, exercise groups, TOPS programs, or others that may help you along the way. As well, many employers offer their employees access to EFAP, or Employee Family Assistance Programs, with a ton of available resources such as stress management, smoking cessation programs, as well as counseling. If you're technology savvy, there are many great online applications that can be beneficial to you as you go forward. These include nutrition or tracking apps, one being MyFitnessPal, stress management apps, and or hydration apps to set reminders to ensure you are meeting your fluid intake needs. Once you have viewed this webinar and would like to proceed with the program, we ask that you advise us by email or telephone within 14 days, and you can do so by emailing us at bariatricsurgery@easternhealth.ca or calling us directly at 777-2038. From there, you will be sent the second webinar on nutrition, and from there, you must complete 2 diet trials, which demonstrate 1 week of healthy eating and 1 week of full fluid journal. What we look for with each of these is that you adhere to the guidelines listed in the second webinar, and you total up all your protein, calories, and fluid to ensure you are meeting the appropriate targets. Once that is completed, you will send your journals into our dietitian via fax at 777-2430 or email at the above address, and our dietitian will review these and get back to you with any feedback before we proceed. Once your journals are reviewed and appropriate, you are booked into the clinic or telehealth site if you are outside St. John's to see the nurse practitioner and the registered dietitian. This clinic visit takes approximately 1 hour, and you will need to bring your medications, food journals, and a record of your blood sugar readings if diabetic. As well, write down a list of any questions you might have. Of note, it is critical that once you complete your 2 weeks of journals, that you continue to food journal every single day and meet all of the targets in the healthy eating diet plan that the next webinar will lay out for you. This is your lifelong maintenance diet that you will follow for the rest of your life after surgery. So let's do a little summary. It is important that you recognize that bariatric surgery is only a tool to aid with weight loss and not a cure. Even though you might want this procedure to be the only thing to be able to help you, this is not the case. In order to maintain success, you need to make sustainable lifestyle changes to reduce your risk of weight regain and the recurrence of diseases that may have initially improved after surgery. Laparoscopic sleeve gastrectomy is a permanent procedure as your stomach is removed, and this cannot be reversed. This is important for you to consider. Diet and lifestyle changes are critical to weight loss, as we have already talked about. Follow-up and adherence with the team increases your ability to be successful, and it allows us to closely monitor your blood work and nutritional status to ensure that there are no concerns. We are always here for you in terms of guidance and support. The behavior change starts now. Practice, practice, practice. Food journal every day, work on meeting all of the targets, focus on eliminating all the caffeine, carbonation, and alcohol, and work to incorporate some form of physical activity that you can do and enjoy regularly. Remember, we are all human and we are not perfect. Sometimes life can get in the way, but it is important to stay on track and be mindful of all the behavior changes that are a necessity to ensure success. It is also important to ensure that you have supports in place to help you along the way, whether that be friends, family, or more formal supports in the community or healthcare system. Listed here are some resources that you can have a look at as you make the decision as to whether or not bariatric surgery is the best route for you to take. Dr. Yoni Friedoff has a website, www.weightymatters.ca, as well as a book called The Diet Fix, Why Diets Fail and How to Make Yours Work. The Canadian Obesity Network has a great website with a lot of resources, and Dr. Arya Sharma has his own webpage, www.drsharma.ca, with some great information for patients as well. As I mentioned earlier, here is a link to watch a sleeve gastrectomy video. Here's a slide of our contact info if you have any questions about anything you heard today, or if you wanted to proceed with the second webinar. Our phone number is listed below, as well as our fax and our email for any questions or concerns. That sums up our presentation about bariatric surgery. This is the road to a healthier you, and we are here to help you in any way. It was wonderful to spend this time educating you on bariatric surgery, and we hope that after this webinar and after watching the second webinar, that you are able to make an informed decision as to if this is the path you use to take. Thank you for joining us and following along.